Let's begin with the program. Our first plenary session will be focusing on the European Health Data Space, very conveniently. I would like to kindly invite the speakers and Kaisa Immonen, the EPF Director of Policy, who will be moderating this session, to start the plenary and just jump into the program. Yep.
Hi everyone, lovely to see so many of you here today. And to kick off this plenary session on the European Health Data Space, may I ask all the panelists and speakers to come on stage, please. We have a wonderful panel with us today. We will have a patient perspective, then followed by a national authority and representatives from the Commission and the World Health Organization. I think that our colleague from the Commission seems to be delayed, probably not surprisingly due to the travel chaos, but let's hope he makes it here. So we will kick off the session and he will get his chance to speak in due course. So basically what we are doing now, and I'm not going to speak too much, I'm going to give the floor to our wonderful interventionist here, is to discuss what needs to happen at European level and at national level to make sure that this European health data space, which is the most important and most ambitious policy and legislative initiative in digital health from the European level, what needs to happen to make sure that it really integrates patients' perspectives, both in its developing and in its implementation later on. And we will have different perspectives. You will get a chance to ask some questions, and we have a little bit extra time now, thanks to the Commission's very brief intervention. So, without further ado, I'll first introduce the speakers, and then we'll get on. So, we have with us Peter Kapitein, who will talk from the patient perspective. Peter is a patient advocate, he's a cancer survivor, and he has founded an organization called Inspire to Live. He connects patients, researchers and clinicians to drive research and treatments and care, both in the Netherlands, where he's from, and internationally. He has years of experience in advocacy and also lectures, rides and fundraisers. He has an honorary doctorate from the Free University in Amsterdam for his work in this field. Then we have from the French Ministry of Health, we have Melodie Bernaux. Dr. Bernaux is the project director on the European Health Data Space in the French Ministry of Health in the eHealth delegation. And she also sits on the steering committee for human rights in the fields of biomedicine and health. She's worked in the French Ministry of Health also on revision of the French bioethics law, including artificial intelligence, and has also worked on secondary use of health data in hospitals. From WHO, we have David Novillo Ortiz. He's the unit head working on data and digital health at the regional office in Copenhagen, and has worked as regional advisor on e-health at the Pan-American Health Organization, and also as an advisor to the Spanish Minister of Health. And he sits on the editorial board of the International Journal of Medical Informatics and does academic work in the UK and the US. You will have all the speakers' bios also in the online app if you wish to see more details. We will wait for Martin Dorazil from DG SANTE to join us from the unit on e-health. So I'd like first to give the floor to Peter. You will present us a patient's vision of the European Health Data Space and what it could do. Yes?
Yes.
Please.
Good afternoon. It's a pleasure and an honor to be here. I'd like to start with a statement. I'm a patient. I'm a cancer survivor. I have a lymphoma, and I think that is my problem. The fact that I have a lymphoma is my problem. I need my physician, I need research, I need industry, I need a lot of people to help me, but in the end it's my problem. So the statement that I want to make for European Health Data Space is make it the problem of patients. As long as we do not make it the problem of patients, it will not work. So many different stakeholders in what I call the medical industrial complex have an interest that is not primarily to benefit patients. There is no bad intention in that, but it's not primarily the interest to benefit patients. There's only one stakeholder who can say we are the patient's voice in cancer. I always speak about cancer. EPF has a much broader perspective. There's only one stakeholder who can say, I am the voice of the patient, and that are patients advocates. So make it your own problem. If you don't make it your own problem, it will not work. In the end, there will come something, but it will not work. Patients want to share. It was 2011, I was asked to give a presentation in Toronto, and actually I could make the same presentation today. Still actual. Nothing changed, really. Patients want to share. After the presentation, Stephen Friend said to me, I think you should travel the world and make presentations about data, and I think you should call your presentation, That's My Data. Because it is. It's my data. I want to share. So who are all the other stakeholders to prevent us to share our data? Patients want to share. Yeah, but there are a lot of hurdles. Oh yeah, there's not enough money. Regulation is a problem. No, patients want to share their data, and a lot of stakeholders do not want to share their data because they have an interest. And always keep in mind, I am not talking about bad intention. That's not the problem. That scientists do their work with our data, and okay, after the publication they want to share. There are tons of data in clinical trials that tell us about failures, successes, that can help. Probably the answer on a lot of questions that we need to solve complex, important problems are in this data. It's our data. So the real hurdle is not money, is not regulation. I come back to regulation in a moment, but is the willingness to really share. So if you build an infrastructure and there is no willingness to share, you've spent a lot of effort, a lot of money, a lot of frustration, and still we do not share. And in 2032, when Kaisa invites me for another panel, I will tell you, 10 years ago, I gave a presentation, and now I can give the same presentation again. So let's prevent that. There is enough regulation. I work at the Central Bank of the Netherlands. I know about regulation. There is enough regulation. Stella told us about trust. I have a question. Do you trust banks? Most people don't trust banks, but they all have their money on the bank. And that is because of trust. You do not trust banks, but you trust that you get your money back if something happens. That is what we organized. So therefore we needed regulation. Absolutely, we needed regulation. We build an infrastructure for payment services. And you could say payments are nothing else than data. Very secure, taking care of privacy. And in Europe, we transfer every day 3,500 billion euros without one mistake. And when something goes wrong, we have a lot of fail-safes. So, on a European level, we are capable of building an infrastructure that is safe, takes care of the privacy, and facilitates the citizens with payments. So why not with data from patients to facilitate patients, to facilitate researchers, to build better treatments, I think that is problem. That is possible. So it's about trust, and it's about taking care of good checks and balances. I think for the use of data, the checks and balances are in place. If a researcher misuses or abuses data, his profession is down the drain. His reputation is down the drain. So I think when industry really makes a mess out of it, using our data, industry will be out of business. Checks and balances are in place. Can they be improved? Of course they can be improved. Everything can be improved. But perfection is the enemy of the good. We need better treatments now. There are diseases, always bear in mind, I always speak about cancer. So the example that I mostly give is about pancreatic cancer, glioblastoma. We made no progress in the past 30 years. And a lot of answers about this difficult question is in data. So we got a job to do. And we are patients. I think the first step that we need to do is make it our problem. As I said in the beginning, as long as we do not make it our problem, it won't be solved. And we're lost. So, also important is that it is not about the data, it's not about research, it's not about treatment, but have the end in mind. And the end is quality of life of patients. So make it your profession to facilitate all these things with data and infrastructures for data, but have in mind that it is about quality of life of patients. It's not about the data, not about the research, not about the treatments, it's about quality of life of patients. So always ask yourself the question, what I do, does that benefit patients? Does it improve the quality of life of patients? And if the answer is yes, do it. And if you are in doubt, discuss it. And if you think no, don't do it. And be aware, there are always hidden costs of saying no. So not making available data doesn't mean we do no harm. If we don't make available data, there is harm. That is what I call the hidden costs of saying no. So I think, again, Kaisa, we need a job to do. Yeah. Thank you.
Thank you, Peter. You raised some very interesting points. I'm sure we'll return to many of them in the course of the conference. Do you still see that in this particular field in healthcare there is more paternalism than maybe in other areas, or how do you see that? Is it still something that people are deciding what's best for patients without patients?
Yeah, and I think that is because of good intentions. Yeah, I mean, in my other business, well, if it goes wrong, that costs money. That's not good, but it's in the end, it's money. And here we're talking about lives. But like I said, doing nothing is not without consequences. The hidden cost of saying no. Yeah.
Certainly a strong case for patient advocacy. Let's hear from France. Dr. Bernaux, please, the floor is yours.
Thank you. Okay. So hello, everyone. I'm very happy to be with you today. Unfortunately, my friend, my colleague, Isabelle, who some of you may know and who's been our head and feet on the French presidency agenda for digital health, couldn't be with us today. So I have a special thought for her. Kaisa asked me to give you a few insights and to share what was our agenda and how we worked during the French presidency of the Council of the European Union in order on the digital health agenda to pave the way for the EHDS regulation. So I'd like to remind you that the French presidency, our French president, he launched the French presidency under three main ideas, which are relaunch, strength, and sense of belonging. Sense of belonging is really what makes us European and what unites us all together. And so it translates on the digital health agenda with the aim to establish ethics prerequisites for the European health data space. We knew the European health data space was coming. We had been working on the French digital health roadmap for 3 years, and we knew that when there's no trust from patients, and there is no use, and when there is no use, nothing's working. So, and I'd like to emphasize that we're all individuals and we're all patients at one stage or another. So when I say individual, it's also patients, and when I say patients, it's individuals. First, we asked our partner, Ernst & Young, to study with us the digital health state of play in Europe. Our idea was to learn from our neighbors how they were already implementing ethics in digital health, how they were placing patients at the center, and to learn how we could do better all together. The main results of this study showed that in every European country, digital health was a top priority. But what was more important was that ethics was used everywhere as a lever for acceptability for the development and innovation done with the European health, with the health data, But what was interesting is that ethics doesn't come in the end. Ethics comes at the start. It has to be the core, the fundamental idea that drives you when you are building solutions for digital health. And considering this and building on the work we've been doing for 3 years in France with the ethical team of the Digital Health Unit, we proposed 16 principles inscribed in 4 dimensions for digital health implementation. And we shared those principles in the end of December with the member states in the eHealth network, and in a record time we built together on this proposition in order to adopt in 4 weeks' time, in the end of January, the Charter for the European Ethical Principles for Digital Health. And I will drive you along those principles. The first dimension is based digital health on humanistic values. So you can see the 4 principles, and maybe we can focus a little on the first and the last one. Digital health complements and optimizes face-to-face healthcare. This reminds us that when you offer telemedicine, telehealth, or teleconsultation, you should always offer the alternative, and the choice should always be up to patient. And the 4th principle is on AI, and it's really about the human supervision of AI, and that it should always be explainable. The second dimension is really an echoing with the Commission study on the implementation of GDPR in Europe on the health data, because we saw with this study that it was rather heterogeneously applied and enforced. So we'd like to remind with this second dimension that individuals should be able to manage their health data. It's not ethics when they cannot. And the first principle is really echoing with what Peter said earlier, is that individuals should actively be involved in shaping the European and national frameworks of digital health. The third dimension is about making digital health inclusive. That is, leaving no one behind, whether for low levels of health literacy or digital literacy, and people with disabilities. We should always provide training and help people to use digital health. And the fourth dimension is the newest one. It's about implementing eco-responsible digital health, because measuring environmental impacts of digital health is also a way to make it sustainable. So those 4 principles, 4 dimensions, 16 principles were adopted by the eHealth network. And you can see the pictures from the celebration, from the adoption, from both the ministerial conference and the 21st eHealth network meeting in Paris. And okay, what next? 16 principles, how are they concretely and implemented? So with the eHealth network, we decided to making the principles concrete and a daily reality in digital health. First, the principles will be translated in all of the member states' languages. Then we've been working for the past 3 months on a supportive document. The supportive document includes an explanation of the principles and use cases from the member states. A European global state of play of the implementation of the principles in the member states will also be soon available. And in the second semester, we'll be building a best practice compendium for from all the ecosystem, and we'll try to open the discussion with the European citizens and with the patients. The idea behind all this is to be sure that we know that today no member states, no industry, no patient representatives, no private sector, no hospitals is already implementing all the 16 principles. But we can learn from each other, we can do better, and we need to do it in order to build trust from the citizens. And working on this, the Commission also proofread the regulation proposal and included the principles. I think Martin, if he arrives, will say a word about it in the regulation. Thank you.
Yeah. So thank you very much, Melodie, for that reflection on the French experience. My understanding is that the French system has actually informed the Commission's thinking quite a lot on the European health data space.
I'm sorry.
That the Commission's thinking on the European health data space has been quite strongly informed by the French system that you have?
Yes, I believe so.
Okay.
All the work we've been doing with the health network and with the French presidency was, I think, inspiring for the Commission. Sandra Gallina told us many times how those principles were important and essential for the regulation.
I have questions for you, but first we will hear from the World Health Organization. David, the floor is yours, please.
So much, Kaisa. Thank you. Good. Thank you. Good afternoon, colleagues. I would like to start apologizing because regrettably I don't have the time management skills that Peter and Melodie has, so I'm going to follow my script to ensure that I am not missing anything. So first of all, I would like to thank the European Patient Forum for inviting the World Health Organization to this session and for giving me the opportunity to share our views about better data for better health. So during the next 5 minutes, I will go over 3 topics. First, I will speak about data in the context of the COVID-19 pandemic, particularly about lessons learned. Second, I will briefly present a call to action with 3 concrete actions that we could help us to collectively continue improving the health data ecosystem. And finally, I will present our approach to operationalize this call to action in practical terms through a regional digital health action plan that we are working right now. So we have learned a lot during this pandemic, ongoing pandemic. In brief, our inability to effectively leverage the volume and different types of data available to us has been a notable shortcoming of the response to data. And this is due to several barriers, including the lack of health data standards related to definition, calculation, and formats of the data. Also, the delays in receiving health data. Also, the lack of integration and interoperability between the different data and health information systems. and also the efficiency of trained people to manage and use this data. So this situation brings home the point that it is imperative that we continue strengthening our data and health information systems. So what does WHO propose to address these challenges? So our first proposal is related to governance. We call countries to establish a high-level data coordination mechanism in charge of implementing a data governance framework composed of multi-stakeholder partners in which patients should have a very relevant and important role. It is key to develop and implement a data governance framework to promote transparency and ensure use of common standards for data collection, reporting, and exchange. For example, we encourage establishing a centralized system to collect data on the correct format that can facilitate proper use and management, including integration, interoperability, and forecasting at the national and at the regional level. In addition, we are convinced that only through the use of traditional and non-traditional data sources, in combination with application of big data and data science methods, we will be able to identify vulnerable populations and develop effective policy responses. The second action is related to investment. According to the Paris 21, the international funding for data and statistics is only about half the level that it needs to be, as established in the Cape Town Sustainable Development Data. Hence, it's important to invest in strong data infrastructures and well-resourced statistical offices that can be useful for policy making. Because I am a bit scared that all the time that we are talking about health data, we are just talking about digitalization without looking at the quality of the data, and that is our main concern. And finally, we call to empower citizens to provide them with the right skills to take decisions on their own health, and to help them understand the rights and the benefits that for risk of sharing data, especially related to ethics, privacy, and security. We are convinced that only through governance, investment, and empowering citizens, we can really make a real change related to health data. Finally, to operationalize this call to action, we are proposing a regional digital health action plan for the 53 countries of the WHO European region. And just a disclaimer, in our case, WHO, the Regional Office for Europe, the scope is for 53 countries across the European region. This plan is currently under review, and it will be adopted hopefully in September during our 72nd regional committee that it will take place this year in Israel. So we do not have, of course, time today to go into detail about this action plan, but you have our commitment that when it's about data and digitalization, patients are always first, and that our plans ensure prioritizing the strengthening of digital literacy skills in the population, and second, that patient associations are engaged in the development of digital health solutions and policies. So thank you so much for your attention. My contact information is in the slide, so looking forward to continue the discussion now with the colleagues and also offline by email, etc. Thank you so much.
Thank you, David, very much for your wider perspective, which is, of course, also relevant as we try to identify synergies between what the European Union is doing and what WHO is working on. I didn't introduce our last speaker, who is by all means not the least, because he had some traffic issues, I guess, getting here. I'm so glad you could make it. Martin Dorazil is Deputy Head of Unit at DG SANTE, Unit B3 at the European Commission. He's a lawyer by background and has worked at the Commission since 2004. And just for your information, Unit B3 is responsible for digital health and also the European reference networks within the larger Unit B, which covers health systems, medical products, and innovation. So we're very, very happy to have Martin here today with us, and you will now give us the Commission's perspective. Thank you so much. The floor is yours.
Thank you very much, and good afternoon, and apologies first of all for the late arrival caused by the European Council and the restrictions that are imposed in the city, but I made it, so I'm very glad to be here and having the opportunity to present you a little bit the European Commission's policy in the area of health data, and especially the recent proposal on European health data space. Let me just check whether the slides that I sent are available or not. Anyway, I will probably start without the slides, and hopefully they will come up in a minute. So as you may be aware of, the European Commission adopted at the beginning of May, so last month, a proposal for a regulation on the European health data space and accompanying communication, which is a political document setting out the main priorities in this area. I can start by a general objective of this initiative, and that's what you can see on this slide. So it's harnessing the power of health data in the first place for people and for patients, and also for innovation. So what is actually the European health data space, and what is that we are proposing? The European health data space is a set of rules, common standards, infrastructures, and a governance framework for the use of electronic health data for healthcare, but also for research, innovation, and policy making. So with this proposal and with this initiative, we are trying to achieve three general objectives. The first one, and the main objective of this proposal, is to better empower individuals to ensure their better access and their control over their personal health data. The second objective is to unleash the data economy by fostering a genuine single market for digital health services and products, and in particular in the area of electronic health record systems. And the third main objective is to ensure a consistent framework for the reuse of health data for research, innovation, policymaking, and regulatory activities. So whilst we are having, these three objectives, and they are closely interlinked, I think for better understanding, I will a little bit, separate them. So the first part of the proposal concerns what we are referring to as the primary use of health data. So use of health data in the context of delivery of healthcare. So we are talking about data related to individual patients that are provided to their treating physicians and health professionals for the purposes of providing the right diagnosis or the right treatment to that individual patient. So in that context, we are empowering individuals and providing them with more and more specific rights to exercise the control over the data, to decide who and which health professional will have access to their data, the right to add their individual data to their electronic health record, the right to request a rectification if there is an error in their electronic health data, and also the right to be informed about who accessed the data of the patient. As part of this first, let's say, pillar of the proposal, we are also introducing the infrastructure, the technical infrastructure for cross-border exchanges of health data for the purposes of healthcare. So, for example, in a situation where a patient happens to be in another country than his country of affiliation to the Social Security, or the country where he lives in, he will be able, for example, in case of an urgent treatment in an emergency department, to provide access to the treating health professional to the essential health data. So, for example, to his medical or her medical history, allergies, previous medication that is being used, and so on, and all that will be in a secured environment using the technology complying with the highest standards of security. With regard to the second of the proposal, then we are trying to address the difficulties that currently are being faced by researchers or innovators, but also by public health authorities or health regulators in accessing data for these purposes. And here we are referring to the reuse of health data for secondary purposes. So here we are not talking about individual patients' data provided to his or her health professional, but rather about large data sets that are being accessed for the purposes, for example, of research projects or for decisions by regulatory authorities such as the medicine authorities. So this is the main, structure of if the main objective is to ensure effective use of health data without compromising the security of the data and including the highest standards of privacy and data protection. As I explained, with regard to the use for the primary use, so for the purposes of provisional healthcare, we empower the individuals to control their data. We propose standardization and mandatory certification of the electronic health record systems to enable their interoperability. And we are introducing a European electronic health record exchange format in order to allow smooth flow of the data and access to that data. With regard to the reuse of health data for the purposes of research or innovation or policymaking, the proposal establishes new health data access bodies in each member state that will be responsible for the implementation of the policy in this area. But it also sets important safeguards to ensure that the data are treated in full compliance with security. So, for example, it explicitly lists the purposes for which the data can be used, and it also lists the purposes that are forbidden, and under no circumstances the access to health data should be provided for those purposes, such as, for example, for the purpose of direct marketing of certain product or for the purposes of using the information to the detriment of an individual, for example, in the context of private insurance where the data would be used to increase the insurance premium and similar cases. We are providing this proposal for a legal framework in order to ensure legal certainty and a solid governance framework, but that in itself would not be sufficient to achieve the full potential of the data in the European health data space. We also need more work and efforts in the area of quality of data and work on improving the semantic interoperability of the data. We also need to put in place the technical infrastructure to allow for the exchanges of data, and we also need to continue supporting the member states in building the appropriate capacity and improving the digital literacy in those member states. And this is all part of the European Health Data Space initiative in a broader sense. So as I said, the health data, they have a huge potential, and the objective of this initiative is to make sure that this potential is fully used. At the same time, we need to make sure that this happens in the environment of trust, and under no circumstances we can compromise the security of this data and the privacy of individuals. So there is a number of safeguards included in the proposal where we are building on the frameworks, for example, on cybersecurity, and we are even strengthening and enhancing this framework. So in the framework of the primary use of health data for the provision of healthcare, the data is accessed only by authorized health professionals following a strong authentication mechanism, and the system fully complies with the current cybersecurity rules, and all member states, before they connect their infrastructure to the system, need to undergo a very strict security audit. With regard to the secondary use of health data or reuse of health data for research or policymaking, there is again a number of safeguards, including the requirement that the data are made accessible only on the basis of a permit that is issued by the health data access body. So without that permit, no one will be able to access the data. The data will always be made available in an anonymized format. in addition, no data it is possible to download from the secured processing environment where they will be made available. So, for example, the researchers can only access the data in an anonymized format and run the algorithms or do the operations they need, but they will never be able to extract or download the raw data that is the basis for their operations. And also all the participants in the infrastructure will undergo very strict security audits. So my final slide shows the expected benefits, or what we expect to achieve with this initiative from perspectives of different users or different stakeholders. And clearly we need to start with individuals, with citizens, and with patients. So this proposal will empower the citizens to have better control over their data, so it will strengthen their rights. But at the same time, it will also remove the existing inefficiencies. So, for example, it will avoid the situations where a patient, because they attend 2 different healthcare providers, need to undergo 2 very similar tests or interventions simply because the results of the previous tests are not available to the other healthcare provider. So it will avoid the situations where there is a duplication of the procedures, which can be very invasive and also costly both for the patient and also for the healthcare system. With regard to the healthcare professionals, they will have better access to data of their patients, so that will allow them to provide better diagnosis and treatment. And with regard to the reuse of health data, this will make sure that the researchers have better access to health data to support their research projects in health area. Health innovators will also have better access to this data to develop new therapies, products, and services. And last but not least, public health authorities and health regulators will have access to data for their informed decisions and will be able to take their decisions on an evidence base. So these are the main features of the proposal. This is still a proposal by the European Commission, so it is now with the European Parliament and with the Council of the Member States that need to agree on the proposal. But once this happens and the proposal is adopted, we hope to start implementing it quickly to make sure that the benefits of health data can be fully used in the future for the benefits of the European patients. Thank you.
Thank you very much, Martin, for giving us this perspective of the Commission and outlining the broad lines of the European Health Data Space and what it will actually be doing. I have some questions, and I will also invite the audience to make comments or questions. But first, I'd like to ask a question to the audience, like in Who Wants to Be a Millionaire? I will ask you 3 questions. Please raise your hand if you have free access to your electronic health record. I expected to see more hands. Okay. Are you able to amend your electronic health record or easily if there's an error in it? Okay, fewer. Are you able to contribute content to your electronic health record? Oh, okay. Nice. This is clearly, I mean, it was we did a little survey with our patient community a couple of years ago now on this, and still, I mean, it's still far from normal to have access across the EU now, not just us in this room, to have free access to your health record, and even less common to be able to actually influence the content of it. So there's clearly a lot of work to do, and if the European Health Data Space can make that a reality as soon as possible, then it will definitely provide added value. I want to ask questions from you about trust, because trust was mentioned by Peter and also by David. And what do you think, esteemed panelists, will secure the patient's trust in the European Health Data Space? And David, you can speak from a wider perspective because obviously you're working with the WHO's initiative. What do you think is the most important thing to make sure that patients trust the system, as you said, not necessarily the individual actors within the system, right?
Yeah.
Can I go first to maybe to you, Peter?
Well,
just go.
In my statement, I said that patients want to share, and ask yourself the question: why do they want to share? Because they think it will improve the outcome of healthcare, when it's not necessarily for their own good, because they're end of life. They want to contribute to the improvement after their life. So I think in the end, I think we should weigh costs and benefits, because if we only stick to discussions about security, about privacy, etc., which are important, but if we stick to that, we will discuss this for many years. And I think we should offer something, because patients want to share their data, and what they see is that it's not used enough. It's used, but not used enough. So in the end, I think it's about cost and benefits.
Okay. Would others like to chip in on this?
I certainly can. I think the first element. I mean, there are probably several elements of the trust that needs to be built or reinforced. But I think the first element is to be very clear about who is in control over data and who decides about one's data. Because, I mean, currently we see, at least in many of the member states, probably based on the poll that we just saw, not in all of them, but in many member states, that the health data are being collected in the process of healthcare and are being processed, but without necessarily, I mean, allowing the patient, I mean, to even be aware, you know, who is accessing my data, for what purpose, and what is happening. So I think that's already the first essential step. I mean, to make sure that it is the patient or it is the citizen who is in control of their data. And secondly, we need to make sure that there are all these safeguards in place to make sure that if the data is transferred or access to the data is enabled, that this happens only within a circle of authorized and trusted individuals. So normally the data is available to a health professional that is under the obligation of professional secrecy, and there are also the technological and legal means to preserve the privacy of the data. But I think the first element is perhaps even more important, really to be clear about, I mean, who is in control of the data, and it should be the citizen.
Yeah, but in my talk, I was telling I also work in the financial industry, and the problems that are now being solved in health data are already being solved in the financial data. So my statement is: learn from that and don't invent the wheel.
Okay.
So in my case, if I may, I would like to emphasize when we are building trust. I think that is a lot about communication, how we communicate. My father has Parkinson, diabetes. I am far from him. He's doing well. I'm not trying to say this with any kind of drama, but digital solutions are evolving, right? And patients are offered digital solutions. And I think that we need to do better in how we are offering these digital solutions. So, for example, to monitor blood sugar, he just received how to download the app in a print one page, and some instructions on how to do it. So how my dad is going to trust an assistant that is just giving him in a paper instructions on how to monitor his blood sugar? So I think that we need to do much better, and we're still not there at all, in how we are building trust with the population in general.
Yeah, thank you for raising the importance of communication. That's clearly something where I think also the patient community can play a role working with the authorities and international organizations to shape communication strategies that will work. I was thinking also when you were speaking, collectively speaking, about participation and co-design, because in EPF, one of our fundamental principles is that in order to make a legislation or a policy work for the individual patient and citizen, you need to build in their perspectives from the start, really. And that means participation through, in our case, collective representative bodies in the policy discussions, in the shaping of the solutions, in implementation. So I'd like to direct particularly my question to WHO and Commission. David, what are the WHO plans to involve patient organization in implementing this regional digital health action plan you just talked about briefly?
Thank you, Kaisa. So one of the so we are all the time requested by the member state to support them about how to strengthen digital health in general. One of the major gaps is how to strengthen governance and how you can really implement digital transformation to improve health systems and services. And our first recommendation is to establish a multi-stakeholder partner mechanism, which patients should be there and the population should be there. Because most of the time, and this is the major gap that we have when we are implementing in digital solutions, is the lack of involvement of the people that will be the consumer of these solutions. And that includes also the health workers. So most of the time, we are missing the importance of involving the key partners that will be using and benefiting from these experiences. So in our case, we will continue promoting the importance of involving the patients and the population in general to ensure that the digital transformation that now COVID is giving us an opportunity, because we have now the digital fever more than ever, so everyone would like to digitize absolutely everything. Most of the time, I would say that without not much sense. And we need to continue supporting that we involve all the key actors and partners to do a proper change that will have an impact in all our lives.
Thank you, David. Certainly the EPF is there as an accredited non-state actor and our members to support you in this field also. Mm-hmm. Martin, of course we have seen there have been several consultations from the Commission and EPF has responded to them all. What else do you see, where else do you see the opportunities to involve a patient community now?
Yeah, thank you. No, I think there is no doubt that the involvement and input engagement of the patient community is essential for the success of this initiative, and we see this also in other areas which are very closely linked. For example, the European reference networks for patients with rare diseases, where we managed already involve the patient organizations very closely in the governance structures of these European reference networks, and we see very clearly that this is very, very beneficial for an advancement in this area. So, as you said, Kaisa, we are building, this initiative on a broad consultation where patient representatives played a very important role, and the proposal that is on the table today is largely built on that input. And in the future, we plan to continue, the engagement of the patient organization. So, for example, what is proposed under the proposed regulation is a new European Health Data Space Board, so a governing body of the European Health Data Space that would bring together the competent authorities or responsible authorities for digital health from the member states. But at the same time, it also refers to the role of stakeholders and explicitly mentions one particular group of stakeholders, and those are patient representatives that should be engaged in the activities of the European Health Data Space Board. So we certainly want to continue that collaboration.
That's very nice to hear, thank you. Melodie, can I ask you about your experience in France when you have been involved in developing these legislations and other initiatives, and what lessons can we take from your experience in this participation and patients?
Well, in France, I was involved in the revision for the bioethics law, and in order to do so, we always organize what we call the États généraux de la bioéthique, which is a wide public consultation lasting for a week, where we ask the main questions on which we aim to regulate to a panel of citizens, and there's really it's really a forum and a discussion, and the legislation builds on it. So I think this is something we can do also at the European level and in digital health. In the bioethics law, there was some input about artificial intelligence, and I don't know if, yes, it's okay.
Yeah.
And human supervision. And this article in the law really came from the input of citizens in the forum. So I think that was interesting.
That's very interesting. We're doing some capacity building initiatives in EPF right now on artificial intelligence to make sure that this community is equipped with the tools to engage in these discussions. We are actually also learning in the process. It's a very complex area, but I think critical. Are there questions from the audience? We have some time, so I'm going to step aside a bit so I can see a bit better. I can see several hands. Okay, gentleman there first. Please state your name first, where you're from, and speak into the microphone for the online audience. Thank you.
Thank you. Thank you for this great conference. My name is Juan Fernando Ramirez. I am a medical doctor and represent as Chief Medical Officer Air Liquide, the French international company. My question is for the French Ministry of Health representative. I think that France developed recently on their SANTE 2022 initiative program about bioethics and ethics by design in order to anticipate that we call human guarantee of access for patients. So my question for you, coming back to the comment raised by Peter, is how this human guarantee can inspire more transparency across European countries in order to increase the access for patients to the patients and critical stakeholders involved in innovation. Is something that can try to solve the questions raised by Peter? Thank you, Melodie.
Thank you for your question. Indeed, in the digital health agenda for the past 3 years in France, we have been building the digital health roadmap on 3 pillars, which are cybersecurity, ethics, and interoperability. In the ethics work group, we published many best practice compendium and recommendations and guidelines on the use of digital health. The latest one is on AI, and it really promotes the human guarantee in AI. But you know, this human guarantee is also in the proposal being currently examined by the European Parliament and by the European Council for AI. I think it's Article 14, and the human guarantee for AI in health is inscribed in the proposal. So how can we build on this to improve transparency? I think when using AI, it's now becoming clear and clear for everyone in Europe that AI needs to be explainable and transparent, and that individuals should be informed when we are using AI for their health, whether it is for diagnosis or for therapy.
Thank you. Thank you for the question. I have one here, the gentleman here, and then 2 in the back.
Thanks. Mine is not really a question. I would like to applaud really the European policy setters on the EU health data space. I'm a caregiver, I'm a scientist, I've worked all my career in clinical trials, but I'm also now a data consultant who works with European umbrella patient organizations on their data strategy. I've read the proposal, and to me it addresses all the major concerns that I have as an EU citizen around my data. And I'm knowledgeable about the topic. Right, excuse me, dry throat. I'm knowledgeable about the topic, right? So I really want to congratulate you. I have friends in the US who are patient advocates. When I read them, all you guys are thinking of, they really just get sad and want to move to Europe. And I don't mean that as a joke. They actually, that's how they feel. And I think it's warranted. So I just want to applaud you, probably with a lot of inspiration from France, because the ethics are very high and very clear. Thank you very much.
Thank you for the comment. I'll go to the back first. There's the gentleman and then the lady here in the front.
Thank you, Kaisa. My name is Dimitrios Athanasiou, Board of Directors of EPF and World Health Organization. I want to be a little provocative after Christian. Congratulations. So, Melodie, France is the most difficult place to share data in research for clinical trials, especially for rare diseases. I would like a comment if you think that this evolution will move France forward, because we need it. Second question is to Peter. Peter, I come from finance. value is something. I mean, donating data for altruism, yeah, I'm with you. But I come from a rare disease. I donate data without trust because my child will die in 15 months. I'm not a patient diabetes, you know, that I want to donate data for the greater good. And Martin, I know the work you do in ERN, so you do an amazing job. How open and how closed is this data? So I saw, for example, you said that we have various stakeholders. I didn't see patient organizations there on accessing. And we're talking about anonymized data. So there is no promotion. There is no, let's say, insurance benefits. Why not to open it more? We are advocates for open data, right? Thank you.
Maybe we'll take the other question as well from the same table, and then I'll give the floor to the panel to answer.
Thank you. My name is Ildiko Vaida. I'm from the Netherlands Patient Organization. And my question is about secondary use of data, the EHDS legislation, while for the primary use, patients will have the right to limit the access of for professionals. For secondary use, there is actually nothing, also absolutely no right. So there is no opt-out, and we are wondering why is that? Because the definition in the proposal is very broad. Health data is everything from my smartwatch to my genome, and genome is per definition not anonymous. So my question is why is that, and what kind of safeguards are going to be built for that?
Thank you for the question. Would the panelists like to answer?
Well, sorry. Can you hear me?
Yes.
I can start on the rare disease and the access to data. As you may know, we have been having the Health Data Hub, which is the place to access the data for secondary use. It has been established in 2019, and it has quite been a success in France because it has allowed people to have a unique access point to all the data we can use for research. Unfortunately, there are many people wanting to access data. So for now, it's a little long to access data, but we aim to tackle this really soon. As for rare disease, you may know that France has a national bank for rare disease data, and which is one of the pioneers in Europe and one of the most complete ones. So fortunately, it will be included in the health data space. It's already included in the Health Data Hub, French Health Data Hub catalog, and it will be included in the health data space. So I think secondary use at the European level is especially interesting for rare disease because of the fewer cases we have. So that's for the answer on the rare disease.
I think the second question touched on the parameters of consent, if I understood you right, and where the lines are drawn between different types of health data. Are you able to comment on that, Martin?
Yes, sure. No, I think there were at least two questions for me. I mean, first one concerned the exclusiveness of the access to the data, or who is actually able to access the data. I would like to clarify that the proposal doesn't restrict the access to data on the basis of the entity or a person that is asking for it. Essentially, any natural or legal person may apply for access to the data. What matters is the purpose for which the data are requested. And there, if there is a patient organization that will request the data for one of the purposes that are included in the regulation, nothing prevents them. And I think that's actually one of the potential beneficiaries. And you're right, perhaps for the next presentation, I may include the reference to patient organizations as well. You know, the slides are limited in scope, but I just would like to clarify that nothing prevents the patient organizations from requesting the access to the data as long as they comply with all the requirements and it's for the legitimate purposes after the assessment by the Health Data Access Body. For the second question, well, one of the challenges or obstacles that were identified in preparation of the proposal and that this proposal is trying to address is the difficulty, for example, for the health researchers to access the data based on the consent. Because, I mean, that makes it virtually impossible for some of the research projects to go ahead. Because, first of all, it is very, very complex and difficult to get this data at all, and the consent from all the projects. Secondly, the rules, although we have the GDPR, that is a regulation in theory generally applicable in the health area, member states are allowed to adopt their national legal adaptations of data protection laws. So the situation is fragmented among the member states. Different rules apply, and it is very difficult for the researchers to find their way through this complex legal landscape. So the approach that we are taking here is that we are ensuring that there is no possibility to identify a concrete patient. The researcher will get access only to the data that is de-identified, only on the basis of the permit, only on the basis of the purposes for which it is requested, and they are not able to download from that secured processing environment the raw data. They will be able only to download, for example, the results of the operations that they run on the platform, but no personal data or no data that will allow identification of a patient will be possible to receive. In addition, what also the proposal includes is it specifically includes a provision that states that any attempt to identify the individual linked to the data is prohibited, and there are important sanctions, financial penalties imposed if the attempt to violate this principle is established. So it makes it explicit that this is illegal activity and should be avoided. So we believe that with these safeguards we are addressing the concern that is there in the health sector, and at the same time we are providing the safeguard needed to preserve the privacy of the data.
Thank you. I think we have time for a couple more questions. I saw one hand up there at the other side of the room.
Hi, thanks, Kaisa. Hi, my name's Lawrence. I run a consultancy called On the Pulse. I do a lot of work in patient education and engagement in rare diseases, based from the UK. Just to set some context, I'm also wanting to pick up on the ethics part of patients consenting. Say at a national level, so for instance, I live with haemophilia. I have an app that I have to input my treatment data use into, which goes to a national registry. Pharma companies obviously then pay certain amounts of money to access that anonymised data, of which there is a total lack of transparency at national level about how that data is used and how that's fed back to the patient community. So I just wanted to understand, with the data space, like, how does that work from a commercial perspective? Because obviously there's a profit motive there. If they want to access that data for research use, how's that? Where's the sort of value generation to the patient community other than just a social contract? What are they actually getting from that?
Thank you for the question, Lawrence. Any views? I've read it a few times that health data is like gold, that it's so valuable.
Every data is gold.
So what do you do about this commercial aspects? Obviously, it's very important also to have commercial entities research and innovate, right?
I would like to respond to that.
Please.
Yes, industry wants to make revenue and profit. So what? As long as they deliver the output, the outcome that benefits patients. You're not going to change the way industry works, but we need industry to produce treatments. Without treatments, patients are literally dying. So that's their interest. That's why I said in my talk, the only one who can speak as the stakeholder for patients is the patient. It's about costs and benefits. And I would love to respond to the questions before. I think there is an obligation for patients to donate their data because we need the data. And a lot of questions, a lot of things I hear are producing hurdles for making it more and more difficult for scientists, for industry, to help us solve the difficult and complex problems that we are facing. Make it as easy as possible to use the data and take care that the checks and balances for the use of data are in place. If a scientist misuses or abuses the data, his career is down the drain. So there is peer review in that, how the scientists use the data. And of course, if it is not anonymized, anonymize it, fine with me, but make it as easy as possible to use the data. And I think we really overestimate privacy. If you look at Facebook, I think 99% of the population is not interested in privacy.
Well, good point. Would you like to comment, other panelists? Okay, Melodie, please.
Yes, please. I'd like to say that on the commercial use, the secondary use in the health data space is only allowed when you have a permit to do so, and the permit is given for specific finalities to use the data. You must specify why you're using the data, which data you want to access, and it's for a certain amount of time, and some uses are prohibited. So we are kind of holding all this together.
I'm sorry, I have time for one question, and that's going to be there, this side. But just before you go, I mean, I did take from Lawrence's comment the importance of transparency and making sure that patients and also citizens more widely understand what are the checks and balances that are in place. Like Peter was saying, we need checks and balances. And so the importance of communication, again, that David also emphasized in his comments. Please go ahead, yours is the last question for this session.
It's more of an observation than a question. I'm a full-time general practitioner in Dublin. I'm the Vice President of European Doctors and an Associate Professor of General Practice. I commend the French Ministry of Health for setting down digital principle in regard to telemedicine, where you have to offer an alternative face-to-face. For too long, many companies working cross-border have been providing lack of continuity of care to patients, which has safety and ethical problems. I'm concerned that it is part of the EHDS legislation, because it seems to be stuck in there as a very small entity, and this has severe patient safety consequences if not dealt with appropriately. Certainly what you've added in there will certainly improve on that, but it should be really a separate entity in regard to this, rather than as an extra within the EHDS. So I commend the Ministry for Health for doing that. Thank you.
Thank you for the comment. Anyone who's interested in the impact of digital transformation on the patient-doctor relationship can follow the parallel session later this afternoon. Now, I think we'll come to a point where it's better to start wrapping up. So I would like to thank you all for being here and ask you to give your final take-home message for the audience. What would you like this audience to take away from the workshop today? Plenary session. David, can we start with you?
Sure, absolutely. Thank you, Kaisa. Well, what to say? I consider myself very lucky each time that I am working for WHO and I have the opportunity visiting countries, particularly countries outside the EU. And sometimes we have the opportunity to meet the senior policy decision makers. And we have the same speech all the time. This is what we have been saying today. You need to improve data, you need to have good data governance, you need to invest, and you need to empower citizens and health workers. And without that, we can forget about any kind of governance mechanism.
Thanks, David. Martin?
Yeah. No, I just would like to emphasize that the data in the area of health, there is a huge potential, and we need to try, to make the use of that potential. We need to do this together to build the trust that we discussed, which is a precondition for the success. So if we work together on that trust, we will be able to use fully the potential of health data for the benefits of patients and citizens.
Thank you.
I totally agree with Martin on that, and maybe in order to build trust, you need to allow patients to be autonomous, that is, to participate in the regulation and to choose who can access the data. It's not enough knowing who accesses your data. What's important is to choose who can access your data.
Thank you very much. Peter, the last word is yours as the patient.
Well, I should say, always have the end in mind, and the end is quality of life. So it's not about data, research, and treatment, it's about quality of life. And also, take care of the hidden cost of saying no.
Very important point. Thank you so much. Can I have a big round of applause for the speakers? Thank you for being here. I hope you've had some food for thought and inspirations for your chat over the coffee and in the next parallel sessions. Thank you for being such an active audience, and enjoy the rest of the conference.